Now we'll turn our attention to affective disorders. We're going to start with depression. Now there's unipolar depression, more common in females. So females are 3 times more likely to be depressed than males. However, the risk for males increases with age, whereas for women, the greatest vulnerability is between the ages of 35 and 45. And with men, it's as they get older. Bipolar disorder is a condition where there's an alternation between periods of depression and periods of mania, although in some cases that mania might be more of an agitated state. Heredity is certainly going to be important, and we're seeing that there is a little bit greater heritability with bipolar disorder than with depression, but both certainly are showing signs of being inheritable. Heritability is estimated at 29% in males and up to 42% in females. Genes that are implicated, though, tend to be gender specific, and so that's why there's a difference, big difference between males and females here. We think it's because the genes that predispose, that increase that vulnerability, tend to be gender specific. Now let's take a look at one of the genes that's implicated. Now there are many genes that are implicated in depression, and probably some that we don't know about. This is just one, but it's a good example of gene and environment interactions. We don't have this level of detail yet with schizophrenia to point to one particular gene and look at how environmental factors interact with that gene to increase the incidence of schizophrenia, but we do have that with depression. So let's take a nice close look at this. So the candidate gene that we're looking at right now is 5-HTT-LPR. So that is a gene involved in the transport of serotonin. And there are 2 versions or 2 alleles that a person can inherit. You can inherit the short allele or the long allele. And so on the left here, we have individuals with either 1 or 2 copies of the short allele of this serotonin transporter gene. And on the right, we have individuals with just the long alleles. Now let's look at the incidence of major depression as a function of stressful life events. So here in the individuals that inherited 1 or 2 of the short alleles, we can see as the number of stressful life events increases, we see a sharp increase in the incidence of depression, going up from about 10%, approximating 35%. So a really dramatic increase in the incidence of depression as the number of stressful life events goes up. In contrast, in individuals who inherited just the long alleles, no short alleles, look at this, it's flat. In other words, their rate stayed at roughly this 10% level, 10 to 15% level. And even with 3 and 4 stressful life events, like these are major things for an individual to go through, 3 and 4 of these major stressful life events were not seeing an increase in the incidence. It remains flat. The long allele then does not seem to pose any vulnerability for depression, does it? But inheritance of at least 1 short allele does. So here we're seeing this vulnerability model. The vulnerability is present only in individuals who inherited the short allele, with the greater, as the number of stressful life events increases, the risk increases for them. Now let's take a look at the antidepressant drugs that are used to treat depression. And from then, it's very similar to the story and sort of the history lesson behind schizophrenia and antipsychotics, where the theories about what is going on in the brain in depression came after this trial and error of trying different types of drugs to treat depression. The first ones to be developed, monoamine oxidase inhibitors. So we will take a look at how these work, but in general, the monoamines include the neurotransmitters serotonin, norepinephrine, and dopamine. They are all very similar in their molecular structure, and so they are of the same class. Later on, we see the development of the tricyclics. These are antidepressants that block the reuptake of norepinephrine and serotonin. We'll see how these work in a moment too. And then we have more recently the development of the atypical antidepressants. These target a specific neurotransmitter. So the most common ones are SSRIs, which stands for selective serotonin reuptake inhibitors, but we'll see that they're also selective norepinephrine reuptake inhibitors. So all three of these, whether they're monoamine oxidase inhibitors or the tricyclics or the atypical SSRIs, work by basically preventing the recycling of the neurotransmitter in the synapse. And by preventing that recycling of the neurotransmitter synapse, it leaves that neurotransmitter in the synapse longer. It doesn't get taken out and removed. Just the method of action is different. And let's take a look at how that works.
Now what you're looking at here are two neurons, and here's one here, the presynaptic neuron, and on the right, the postsynaptic neuron. The signal will be coming through this neuron, across the synapse, and through this neuron. I'm going to draw out these small yellow balls, which I'll refer to as molecules of serotonin. Now, let's assume that this neuron on the left here has released serotonin out into the synapse to be communicated to the neuron on the right here. All right? So what's going to happen is it's going to cross the synapse. Now, some of them will take their places over here on this neuron. All right? Some of them will go through and continue the signal. Now, however, some molecules of serotonin are left behind in the synapse. Now, what happens to them? Well, two things. Some of them can be reabsorbed into the presynaptic neuron. Okay, that's called reuptake. Others are destroyed, and they are destroyed by some enzymes, which are referred to as monoamine oxidase. Now I'm going to use this little symbol here from the Pac-Man days to indicate that that MAO is destroying that serotonin molecule.
So as you can see, something that will inhibit monoamine oxidase will leave all of the monoamines in the synapse to act longer. And so the older drugs are often referred to as MAOIs. They are inhibitors of that enzyme that breaks down the monoamines, leaving those in the synapse longer, increasing the supply available to the receptors. And then the ones that block reuptake do a very similar thing, just through a different means, preventing the reuptake, that removal of the neurotransmitter, and putting it back for future release in the presynaptic neuron. Now, interestingly, we're going to see smoking be a factor in depression, just like we saw it in schizophrenia. The ingredients in tobacco act as a MAOI, so as a monoamine oxidase inhibitor, and indeed about 80% of affected individuals self-treat their depression with tobacco as well. Now, here's an interesting question. Okay, so we have these different classes of antidepressants. They accomplish similar goals, but through different ways. Do they differ in terms of their efficacy and their safety and side effects? Well, let's break that down. Safety and side effects, yes, they do differ. The monoamine oxidase inhibitors are not the first choice of treatment right now because they are a little bit harder to manage. People's that are on them have to sort of watch their diets a bit and be cautious of any medications like over-the-counter cold medications they might take, because there could be difficult interactions with them. And so they're a little bit more challenging because of that. But they all have side effects and they all pose risk factors. that are a little different. So there are some, subtle differences there between them. However, in terms of efficacy, and we talk about efficacy, we're just saying, how effective are these things? No difference. And so the antidepressants that were developed in the 50s and 60s are just as effective as the ones that are developed now. And that's not a good thing. We would have liked to have seen an improvement in efficacy over those decades, and that really has not happened. So there are a substantial number of people who are on antidepressants but do not get any benefit from them. Now let's take a look then at just some of the understanding of what might be going on in depression based on learning what these drugs do. So if we remember, the use of these monoamine oxidase inhibitors led to something called the monoamine hypothesis of depression. And that monoamine hypothesis of depression states that depression is due to what? High or low levels of the monoamine neurotransmitters in the brain. So if these drugs leave them in the synapse longer, then we can assume that what's wrong is that these levels are too low, right? Normally in the case of depression. So we would answer that, say, depression is due to low levels of the monoamine neurotransmitters in the brain. Likewise, use of the SSRIs, selective serotonin reuptake inhibitors, led to the serotonin hypothesis of depression, which states that depression is due to low levels of the neurotransmitter serotonin in the brain.